Pathology, which will be taken by none other than Dr. Anita Borges, ma'am. She is the lab director and pathologist from Center of Oncopathology, Mumbai. I welcome you, ma'am. Today, we have 8 students from across India who will be interacting with us. Dr. Mansi from Bhopal, Dr. Ishita Chandra from Darjeeling, Dr. Kiran from Haryana, Dr. Kinjal from Jaipur, Dr. Tinu from Thrissur, Kerala, Dr. Ambika from Secunderabad, Telangana, Dr. Jyoti from Banaras, and Dr. Manasvi from Dibrugarh, Assam. The next slide seminar, which is on the next Thursday, will be is on how to describe the blood cells, and this will be taken by Dr. P.G. Subramanian, sir. He is a professor and head in hematopathology in ACTREC, Navi Mumbai. Today, myself, Dr. Sakshi from Guwahati, Assam, and my colleague, Dr. Bonita Bora, she is also from Guwahati. We are the moderators, and we are thankful to our webinar host, which is hosted regularly by Center of Oncopathology by none other than Dr. Anita Borges, ma'am, and Dr. Sumit Gujral, sir, from TMH, Mumbai. So there are a few reminders. If your video is freezing or there is interruption, you can just leave the meeting and rejoin through the same link. And if there, though there are no poll questions today, but you can ask your questions in the chat box. Annotation requests will be taken by our selected students today. So I request others not to send the annotation request. These are a few disclaimers. These are a few other disclaimers. And this is about the next upcoming slide seminar, which I already told Thursday ko Dr. Subramanian sir's slide seminar on how to describe blood cells. And on the next Monday, we will be having approach to peripheral blood smear taken by Dr. R. Chandra. So students, let's start. I'll stop my presentation and I invite Anita ma'am to please take the seat.
Okay. Good evening, everybody. Is there an echo still? I don't think so. I think it's gone. All right. All those who are not students can mute themselves. Okay. The students, I need them to not mute themselves so I can talk to them and they can talk to me. All right. You've already had one talk, and that was last Thursday by Dr. Siddhartha Dattagupta, and he did the language that pathologists speak in a way in which he was describing a whole lot of words that we use in pathology. Okay, and he went very systematically all the way from A to Z. So you might say that he was talking about the A to Z of like a dictionary of the words that we use in pathology. Now, essentially, I'm sure all of you know that we speak English, okay? And it's that English which has some specialized words. So if you're speaking English and learning engineering, or you're learning any other professional course, there will be general English and then there will be specialized English. And we have to learn the specialized words and the way we use them in pathology. Yes. So I think that that's what this is, the second in that particular series. You will have in hematology now, you've seen that you will get Dr. Subramaniam and then Dr. Manchanda, who will tell you about how to describe things in hematology. Because after all, what do we use language for? We use language to do many things, yes? To express our thoughts, yes? We also use, there is an echo and I don't know why there is an echo, but we also use language, particularly in when we're telling a story, yeah, and we want to describe something. And when we want to describe what we saw or what we did, then of course language helps us to do that. And I think that we as humans have really taken this whole language issue and taken it to the nth degree, because look at the number of languages as we speak all over this earth. Yeah, even people who live next door to one another in regions that are next door to one another have their own little nuances that are changed. So you may speak Hindi in the north in many areas, but regional Hindi is different from different areas, and we have to learn the language if we want to understand what others are saying, and if we wish to be understood. Okay, now today I'm not going like this from A to Z. It's many of the words that you heard the last time maybe are not going to be repeated, but there will be some repetitions in this, because in today's talk, because now I'm talking about patterns. Okay, so before I go to actually describing patterns, I said that we need to speak this language because it's going to help us to make a diagnosis. Okay, so what is the essential sequence for making a diagnosis? Now, all the students over here are second year, except for one student who is Ankita, and Ankita is a third year student. So you have had some experience in using the language. You have had some experience in making diagnosis. I don't know if there are any first year or very young pathologists who have just joined the pathology stream, but if they are, it is as well to get your feet well established on the ground floor. And here is an essential sequence for making a diagnosis. And when you look at this sequence, which I have put up over here, don't think that it only applies to histopathology. Okay, it applies to clinical medicine, it applies to hematology, and it might apply to a clinical pathology, urine examination, or any other test that we might want to do. And it starts with making good observations. And the observations are either positive or negative. Now, the positive observations are obviously more easy to make when you see something, you elicit a sign, yeah, it's positive. Negative ones are a little different, because negative means that you are expecting something there and you don't see it. Now, if you're not familiar with a particular entity or say a particular clinical situation, you may not be looking out for the negatives. Okay, but as you progress in your profession, you will know that this thing goes with this, and if I'm seeing this and I don't see that, then there is something that should attract my attention. Okay, so positive, negative. Then what we have to do is we have to interpret these observations, and we interpret them so that we are able to go forward. And normally when we make an interpretation of the observations, we have come very close to the final diagnosis. Okay, so as we go along, you will understand what it is that I'm talking about. If we are not able to sort of reach of a diagnosis in these two steps, then obviously we need some appropriate investigations, whatever those investigations are. And in histopathology, we can do special stains, we can do immunohistochemistry, we may sometimes want to ask for a molecular test. But think if all this is applicable, say, to a clinical situation. You made some observations, you have interpreted the observations, but you still haven't come to a clinical diagnosis. Then obviously, you know, you have all been through this in your MBBS. You have to ask for appropriate investigations. It may be an X-ray chest, it may be some blood tests or whatever. Yeah. And then after you have got this preliminary stuff, you analyze it. You see how all this fits together. That's what is called analysis. Okay. It's not just looking at something and trying to recognize it by just recognizing, where have I seen this before, where have I seen this before, and seeing, you know, matching book pictures or something. You are now doing an analytical exercise, and for this you need not just memory and recall, you require to use your God-given intelligence. And every one of you is intelligent, but perhaps your intelligence has not been stimulated. Certainly, it is not stimulated by coaching classes, because coaching classes just ask you to memorize the stuff, the information that they give you, and then recall it. Okay, so we come to the analytic part of this. But you know, it's very hard, or it's, I would say, inappropriate to do an analysis outside of a certain context. Okay, and what is the meaning of context? Does anybody over here, any of the students, know what is the meaning of a context? Ishita, what is a context? Do you understand
Ma'am,
this
I
word
think
context? Yes?
context means preference, like which we are preferring. In which
Something that
context we are speaking.
you are preferring. What does that mean? What is a
Means
context? Can you tell me? You're just using the same word again. But what is a context? All right. If anybody else can answer. Kiran, what is a context?
Talking about the said subject and
Talking about the subject. Okay. Ankita,
Ma'am, in relation to, हम like related to something, like इसके बारे में हम बात कर रहे हैं, which is related to something.
it is related to something. Okay. That's what Ankita says. Kinjal, what is a context? How would you explain it to somebody? What is a context? I'm not, yes, somebody is writing in the chat box. Something is saying correlation or coordination between things. Nimal is saying background. Yeah, so what does Kinjal say? What is Kinjal saying? What is context?
Meanings of some
What,
terms.
sorry? You'll have to speak up louder, Kinjal.
Particular meanings of some terms.
Meaning of some terms. That's not a context. That is semantics. Okay, Tinu.
background information. Background meaning.
Background information. Yeah, some people are talking about background. Manasvi,
Background information or environment.
you also think it is background.
Is to say
Mansi,
Related to, like,
related to. Okay. So if I am related to somebody, is that a context? No. Sharanya is saying something. What is, oh, sorry, I missed it and it's gone. Circumstances, says somebody in the chat box. Ambika, what do you think is context? Huh?
If we want to come to a certain diagnosis, what are the tests we want to know and the history, everything, if we want to know the proper history and background
No,
of that.
not quite, Ambika. The word context means framework. Okay, so when I am trying to make an interpretation, and I have done investigations, I've made observations, and now I have to come, I am analyzing something. I cannot do it outside a framework. Okay, that's the context. Why? Because that framework actually decides what something can possibly be. Now, some people use the word background. So it is all the information that we know about some particular case that we are studying. Okay, that is the context. Everything adds to the context, right? So if I'm looking at a bone tumor, I have to know, and I'm looking at the histology, and I'm seeing some osteoid, and I'm seeing some cells that are producing osteoid. All right, I cannot make a diagnosis on this and say, oh, here is a tumor. I made the interpretation that these cells are laying down the osteoid. I've even done some immunohistochemistry and shown that those cells are actually osteoblasts. Yeah, but without context. And for this context, I need to know where has this biopsy, which is showing these osteoblasts and osteoid material, where has it come from? Is it sitting in the cortex of the bone? Is it sitting in the medulla? Is this a disease outside the bone? Or is it within the bone and it has destroyed the cortex and is now also in the soft tissues? Okay, and for this context, I need a radiograph. Okay, so I need an X-ray. Otherwise, I'm sorry, I cannot do this interpretation and analysis and everything without that X-ray. So please understand that that is the context. Which bone is it? Is it a long bone? Is it a flat bone? Where in the context of the cortex and medulla is this? So it is within a certain framework alone that I can make an analysis of the investigations, the observations, and the interpretation that I am making from these observations. Now, this is very, very important. Okay, I see a lymphoma and I see all those lymphocytes and I see they are very, very mitotically active, and I know that this is a high-grade lymphoma. Okay, and I need to know, is this a young person, or is this an adult? Because I cannot make that analysis outside of the age of this patient. So we need information, and all the information that we can collect about that particular case that we are studying gives you the framework within which you can make your analysis. And that is called a context. Okay, so the context is really the framework. Then you come up with differential diagnoses. Now, what are the possible diagnoses in which all this observation and your analysis and everything fits? Once you have made your differential diagnosis, you go back and you think, which are the possibilities that you can prioritize over the others? So you can't say that these are all the differential diagnoses. Is this more likely than that? And you put it in the list of what is more likely to occur than everything else. And then you can look at the context, look at everything and say, yeah, I don't think that this is going to fit. So I knock it out of my list of possibilities and so on. I'm sure all of you do it. That's how we've done it in clinical medicine. This is how we do it in pathology, whether it's histopathology or hematology or any other thing. Once you have narrowed down the possibilities, you might at that stage say, oh, now I think I need to get some other tests, or I need to get some more information about this patient. Okay, and ultimately you reach a final diagnosis. This is the sequence by which we make a diagnosis. Okay. Now, if you want to improve your diagnostic skills, you have to make a good description. And here comes the issue of the language that pathologists speak, because you cannot describe unless you know the language in which to describe. And a good description is a matter of observation plus an interpretation of that observation. Okay, what does that observation that I have seen, what does it actually mean? How do that observation, how does it relate to the case that I am looking at? So that's what a good description is all about. Now, to be able to make that observation and interpretation, and to do a good description, you have to be familiar with normal histology and its variations. If you don't know what is normal, I'm sorry, you cannot be doing pathology, which is essentially about abnormal. Okay, so all medicine is not about abnormal, but pathology certainly is. Okay, obstetrics is part of medicine, but obstetrics is not about abnormal. Pregnancy and delivery and all of that is absolutely normal, but it comes under medicine. But pathology is definitely abnormal. Okay, very good. We have to learn how to use professional terms. And that's what I mean, the language that pathologists speak and understand. That is very important in a description. And you have to really know what those terms mean. And otherwise, I think you're going to be misunderstood. You are probably misunderstanding your own observations. Okay. Now, how do I describe a good description? A good description is one, and please pay attention to this, that will allow an experienced individual. Okay, and one day all of you are going to become experienced. But as of now, okay, one that will allow an experienced individual to render a diagnosis without having examined a slide. What does that mean? That if I am, and I've said that in the next thing, a good description will make a blind woman see. Okay, now I'm a very experienced individual. I like to think that anyway, as a histopathologist. Now, if you have made an excellent description, good observations and good interpretations, and you have seen the slide, because I cannot examine the slide, or I have not examined the slide, or you are seeing it and you don't know what it is, and you have phoned me on the phone and said, I am seeing this, this, this. If your description is good, so good, that I can actually see what you are seeing because you have made such a good description, then I will be able to make the diagnosis, even if you are not so experienced that you are not able to make that diagnosis. I hope you understand what it is that I'm saying. Okay, so just to put all of this in a nutshell, this description is a system of examination, okay, used within a context which, after an analysis, will lead to an appropriate diagnosis. So that really is what a good description is. But it's not just a random description. There has to be a system by which you examine a slide. Okay. And this is one system that you can use. And this is an algorithmic system. And what is it? You have made your observations, you've made your interpretation, and now you have to analyze your observations and interpretation. And you can start by asking yourself questions that pertain to an algorithm. And here you are, ask yourself this question: what I am looking at, is it congenital? Could it be congenital, or is it acquired? Okay. And if you come to the conclusion that it is acquired, then you ask yourself, is this what I'm seeing? physiological or pathological? And you might say, hey, what physiological? I'm doing pathology. Okay, so it has to be pathological. No. So many of us get things like curettings from an endometrium, or somebody has taken out an appendix, or somebody has taken, and there is no real pathology over there. Okay. Sometimes you have got a curetting from an endometrium, which is absolutely physiological. It's a proliferative phase endometrium. There's nothing pathological about it. Okay. So you see products of conception. It's come to you, and you are looking at it. Just because it's come to you and you are doing pathology, it doesn't mean that everything that is acquired is necessarily pathological. Okay, now you have made up your mind that it is pathological. Then comes one very important distinction in that algorithm. And it is it neoplastic or non-neoplastic? Okay, because if it is neoplastic, then the algorithm takes you in another way, and that way is this benign or malignant? Right? If it is benign, you should be able to reach the final diagnosis by looking at all the tests that you have done, etc. If it is malignant, you don't, if you miss the next step, and the next step says, is it primary or secondary or metastatic, whichever word you want to use for secondary. Okay? Say you've got a tumor that has come out of the parotid gland. You know it's malignant and it looks clear cell. And you'll say, yes, it is a clear cell carcinoma of the parotid gland. No, it may not be. If you miss this step and you are not asked yourself this question, is it primary or metastatic? You would probably ask the clinician, has this patient had a renal cell carcinoma, clear cell renal cell carcinoma, ever has he had it? Or can you find out whether the kidney is in? Because it's not unknown for a metastatic clear cell renal cell carcinoma to present with a metastasis in the parotid, or present with a metastasis almost anywhere. Okay, so you have to ask this question, what I'm looking at after I made up my mind that it is a malignant tumor. Right? Is it primary or secondary? And then, of course, you reach the final diagnosis. If it is non-neoplastic, then you have a lot of things to consider. And maybe I should ask now, Ankita. Ankita, you're doing your third year, right? When are you going to do your exams, Ankita?
Ma'am, this October, September or October.
Oh, so it's very close. Now you see all these bullet points that I've put over here. What are they, Ambika? If you think that something is non-neoplastic, sorry, not that way. If you think that it is, yes, non-neoplastic, you're sure that it is not neoplastic. What are all these bullet points that I have put up over here?
It can be cell injury, cell death, adaptation.
Yes, I know that. You're just reading it. But what does it remind you of, these things?
It can be a normal process where the
normal process. I don't think that diseases of the immune system are normal processes. Metabolic disease is not a normal process. Inflammation is not a normal process. So look at these bullet points, please, all of you, and tell me, where have you seen these bullet points before?
And these are the chapter of Robbins.
Who said that?
First
Who
chapter.
said that?
General
said that?
pathology.
First chapter.
Yes, whoever said it, these are the chapters in general pathology. Okay, so whoever said it, or all of them, and several of them are saying it in the chat box. Yes, these are the chapters in Robbins. So if something is non-neoplastic, then we have to see where does this non-neoplastic process, because it's always a process, fit. Does it fit into one or the other of these, or is there a combination of many things? Okay, because each one of them can happen alone. It may happen in conjunction with others. You can have inflammation with repair. You can have injury with inflammation. You can have diseases of the immune system, which give rise to various kinds of inflammations because you are susceptible to so many different organism or whatever. And then you get inflammation, and then there is repair, and so on and so forth. So this is how you go about trying to fit whatever you are seeing into one of these general pathology chapters. And most people just skip over the general pathology chapters because they think, oh, it's too hard or there's too much to remember. It's better to go to systemic pathology straight away. Okay, good. So now we come to, if you are able to do this, then we can talk about patterns. Okay, anybody want to tell me what is a pattern? Can you describe, just like somebody described, or we tried to define a context, how do you define a pattern? Come on, Manaswi. How do you define a pattern? You know, we all know what a pattern is, but when we have to define it, then we have problems. Yes, come on, Manaswi, what's a pattern?
It's a regular arrangement of things.
An arrangement. Yes, very good. It is. It is an arrangement. It's an arrangement which tends to have some degree of repetition. Yeah, that is a pattern. If everything, there is no arrangement at all, and everything is haphazardly placed, then you say that something is patternless. Okay, good. Lots of people, some people are saying architecture and so on. So a pattern forms an architecture. Architecture is not a pattern. Okay, so you know that some say a building has an architecture, but there is a pattern to that building, right? And you can go right down to the pattern of the bricks, but then there are other patterns. There are domes and there are other things, and all together it forms an architecture. And then you say that this is the architecture of the Mughal era. This is an architecture of the modern era. Okay, so pattern is not about architecture. Pattern is, so this is, so whoever said arrangement, and very good, Manaswi, it is an arrangement. It is especially a design, okay, made from repeated lines, shapes, or colors. And it's usually on a surface, okay? So there you have it. It has to be on a surface. You look at the patterns on the in the tiles of your bathroom. Are they all one above the other? Or, you know, there is a pattern in which one row is different from the other row because there is the line of the tile comes in the middle of the next tile and so on. Okay, so that's what it is on a surface. Now this is, this is I've taken this from a dictionary so that you understand it. Okay, and patterns can be gross or they can be microscopic. Okay, and we use different terms for gross patterns and different terms for microscopic patterns. Okay, now what do we do in histopathology? Histopathology describes who's talking. Who is talking over there? Somebody's talking, somebody's coughing, somebody, please. Okay. So histopathology. Tinu, you are talking, or to somebody else, please. Okay. Histopathology describes a two-dimensional surface. Okay, that's why we call it a pattern of a three-dimensional object. You know that. In histopathology, we are taking thin sections and we lay them out flat. And that three-dimensional object we are talking about is the structure. The three-dimensional, the pattern doesn't form a structure. It is the three-dimensional shape of this thing that forms a structure, because the same a same structure can look different depending upon what dimension it has been cut in to form a surface. So if I'm looking at a long, narrow tubular structure, okay, and I cut it along its length, yes, it will look long and narrow. It'll form that kind of pattern. But if I cut it transversely, then it won't look long and narrow. It will look like a little set of small circles, if it is a tubule that is tubular structure that is hollow, or it will look like little complete circles because you have cut something. So it's important to understand the difference between structure and pattern. Okay. This is another thing that you have to understand. The characteristics of individual cells, okay, do not by themselves define the pattern. Now, what do I mean by that? Here, clear cell tumor describes the cells, not the pattern in which the cells are arranged. Yeah, this is very important because I see terrible descriptions and I say, what's the pattern? And they say clear cells. Clear cells is not a pattern. Clear cells are defining individual cells which together, either, you know, if it's a line or a shape or a color, and so each cell is one of these things. It's a shape that is together. When they join together in an arrangement, they form a pattern. So if you say papillary clear cell tumor, that describes the cells and the pattern, which in this case is papillary. Okay? And spindle cells, for instance, can be arranged in several patterns, each of which has got diagnostic value. And we'll see. We can't see everything, but we'll see many things. Now, here is how a description is. Floral pattern. Okay? Each one of us can make out that these are flowers, these are leaves. So this is a floral pattern in 3 different stitches. So if these were cells, these cells are all different, but each one of them, each of these cells have joined together to form a pattern that is recognizable as a floral pattern. Okay, so don't confuse cells with their arrangement. So the same cell same lot of cells, same shape of cells, for instance, can be arranged in different patterns. Okay, so that's something that you need to understand. Okay, now patterns are best appreciated at low power. And what do we do at low power? It's not possible for me to go into all of this, but we ask ourselves 5 questions at low power. When I'm making observations and interpretations, I'm asking myself 5 questions at low power. I ask myself different questions at high power, but at low power, I ask myself, is there any normal tissue? Okay, can I recognize any normal tissue there? Is there any abnormal tissue? And you might think it's so funny. This is pathology and there should be abnormal tissue. No, I just told you. You can get a normal endometrium, all right? You can get a normal appendix in which the inflammation has subsided, and we make silly diagnoses of chronic appendicitis when there is no such thing as a chronic appendicitis, okay? Is there any abnormal tissue? If there's normal tissue, there is abnormal tissue, then you have to ask what is the relationship of the abnormal to the normal. If you say you have the gut and you have the mucosa and then you have the submucosa and you have the muscularis and you have some disease there, whether it's inflammatory or neoplastic or whatever, you have to ask, where is this disease actually starting? Is it starting in the mucosa? Is it starting in the submucosa? And there are different diseases that start in different places, so that's important. But what we should be looking at is what is the pattern or patterns of this abnormal tissue. And you can see this at low power. You see the the pattern, which when you go to high power sometimes, that pattern may become clearer, but it may show you sub-patterns as well. So you may be able to see one pattern at low power, and when you go to high power, apart from the cells and what kinds of cells they are, and whether you can see the cytoplasmic membrane and the nuclei and so on and so forth, you can also see whether there are sub-patterns which you could not appreciate on the low power. And the last question that you should ask is, where should I begin my high power examination? Okay, now, so now patterns in histopathology. Okay, you don't have to mug this, please. And the other day, somebody was asking, in the chat box, I saw it when Siddharth Dattagupta was, it was almost like we have to mug this up. Can we please see this again and again? You don't have to mug it. You just have to understand the subject. And when you become a little familiar with what you're looking at, and which I hope you will become familiar, you will see the sense of how to examine patterns and what these different patterns are. Okay, so patterns are cellular patterns of growth and organization. So when you have a pattern of growth and organization, you can actually make out what this is. Tissues are nothing but cellular patterns of growth and organization. You see that. The liver looks like the liver because it is made up of liver cells and other cells in a distinct pattern of organization. Okay, so you have the cords, you have the canaliculi, you have the sinusoids, and the way that they are all put together around a central vein, and you have these portal tracts, at the periphery. All that is a pattern. That's a normal pattern. Okay. Then you have stromal reactions and extracellular matrices. You know about the extracellular matrices that you see in normal tissues, cartilage and bone and collagen, and sometimes even myxoid tissue, like you see normally in the cord, in the umbilical cord. Under pathological conditions, you can get the same extracellular matrices, but in an abnormal, laid down in an abnormal pattern, or you may get some very odd looking stromal reactions, which are part of the pattern of that you see in, say, inflammation, or you see it in neoplasia. All this is what we should be observing when we're looking for patterns in histopathology. Now we also see patterns of cell death. Okay, those of you who are studying this in the second MBBS, and Ankita has already reached the third year, the way that cells die as well, whether it's individual cell death, whether a whole group of cells have died, how have they died? Okay, what kind of patterns of cell death are there? Very important for us to recognize, because it helps us to make a diagnosis based on the patterns of cell death. All right, patterns can be repetitive, they can be variegated, and sometimes you don't have any patterns. Okay, it's just sheets, and in which the cells all look the same. Which for this term we say monomorphic. Morphic meaning appearance. Yes, the morphology of something. What is its appearance? And when it's mono, it means all one. And the same word, sometimes used in a different context, but it's the same word. We use the word monomorphous. Okay, and most often monomorphic and monomorphous lesions are patternless. They don't seem to have any pattern that you can discern. Okay, just to show you what I mean by patterns of necrosis. Now, all of you have seen some of these patterns. So now we should ask, Come on, Kiran, this first left-hand side thing. You can see the necrosis. This pink stuff is got no nuclei. You can see these are spindle cells over here, and they are nucleated. I'm very sorry. So they are alive. Okay, they're not dead. Here is necrosis. Now, what pattern of necrosis is this? Come on, Kiran. Have you ever seen this pattern of necrosis, and what would you call it? Yes? Somebody saying tombstone. No, it's not tombstone. Who is? Yes, somebody said geographic. Very good in the chat box. What would you say, Kiran? Sorry, whom was I asking? Yes, Kiran. Kiran, what is this pattern? Do you agree that it is geographic? Huh?
This one.
Yes, ma'am. Why do you think it's called geographic, Kiran? I said very good, so you assume that this must be geographic. Why is it called geographic?
This looks like
Yes, very good. It looks like what? This, number one. Yes. On the left-hand side. What? Yes, somebody's answering in the chat box. Come on, you were going to say something, Kiran. You know what it is. Come on. Why do we call it geographic? Kiran, are you there?
yes, ma'am.
Yes, good. So come on.
It
I'm
is
going to say something, and I know it was on the tip of your tongue, so say it.
It is called geographic because it resembles.
Because. All right, Ankita.
Map, ma'am, because like a map, no definite boundary.
No definite boundaries. So
Ma-
you
ma'am,
mean that
boundary-
in an
ma-
atlas, the maps have no definite
ma'am,
boundaries, Ankita?
map is there, but due to map, like we cannot tell it
What?
any other. We cannot refer it to any other pattern. Like it's map like, so it's geographic. That's why
It's
we call it
map-like, so
pattern.
geographic. But you just told me that the map-like is indefinite. It's not indefinite at all. Every map, if you take the map of India, okay, the map of India has an outline which is very definite. Yes or no?
Yes,
It may,
ma'am.
it
Sorry,
may
ma'am.
be irregular. Huh?
Irregular. Yes, ma'am. Irregular.
No, whether it's irregular or irregular, it
Okay.
has a defined outline and border. Okay, you can't
Yes,
have
ma'am.
a fuzzy outline of India or a fuzzy outline of the United States. Worst, I mean, even better, you can't have fuzzy outline of the states inside India. Yeah, Maharashtra has a shape. Gujarat has very defined. It may be irregular, but they are defined. All right. If you go to the United States, I don't know how many of you have looked at the shape of the United States. The individual states don't have irregular borders. Many of the individual states have got straight lines. Okay. So it's got nothing to do with irregularity. It is about defined lines like they are drawn on a map, and the shapes of that are made are like the shapes of either of continents, of countries, of states, islands on a map. And that's why it is called geographic necrosis. It is extremely well defined. Yeah. Now, come on, Ankita, since you did this, can you ask for annotation, please? Ask me for annotation. Come on, Ankita.
Okay. Yes. Yes, ma'am. Yes, ma'am.
Quickly.
Ma'am, I have sent the request.
No, it hasn't. Here we are. All right. Come on. Come on, Ankita. Now take the second pen. All right.
Yes, ma'am. Yes, ma'am.
The one under the arrow. Yes.
Yes, ma'am.
And take a color, say any color, but take white or blue or something.
Yes,
Yeah.
ma'am.
And now draw the outline of this necrosis, please. so that everybody understands that is what. Yes, look at that. Actually, it looks like an amoeba, no?
Yes, ma'am.
Exactly. So you take this one, look at it. See how sharp is the outline of this thing. And whatever she did was beautiful. Okay, look. Very, very sharp. Now, the next time you see something like this in a tumor, you know that this is geographic necrosis. Okay. So this is one type, one pattern of necrosis. There are many patterns of necrosis. I'm just showing you some patterns. There is something that you get which is called palisaded necrosis. Okay. And what is palisaded necrosis? Palisaded necrosis will be, which is not shown over here. Palisaded necrosis will show you, let me take a, all right. You get an area of necrosis in the center. Yeah, it may be of any kind, but that's the area of necrosis. All right. So I'm shading it so that you know that it's the area of necrosis. It may be regular, it may be irregular, it doesn't matter. Okay, maybe somewhat like that. But at the periphery of this, you will have a row of cells. They may be histiocytes, they may be tumor cells, and the row of cells on their nuclei will be placed like this as a palisade, and very soon we will see what a palisade actually means. These are nuclei of either histiocytes or tumor cells or whatever that are all parallel to one another and perpendicular to the outline of the necrosis. Okay, so this is what is called palisaded necrosis. And you see this in glioblastoma multiforme. You also see it in cat scratch disease. So it doesn't have to be in a tumor. Okay, so
I have a question, ma'am.
who's asking the question?
Kiran.
Yeah, tell me who's asking the question.
Ma'am, how is this palisading pattern different from picket fence, or are they both?
It's the same thing. A picket fence and a palisade is the same thing. Okay, so then there's no difference between picket fence. But who asked the question so I can address you by name? Who asked?
Kiran.
Kiran. Okay, very good. So this is, if this was all necrosis inside, yeah, then this is what is called palisaded necrosis. All right. Now, what is this number 2? This thing. What kind of necrosis is this? Anybody who wants to take that? Kinjal. What kind of, you can see that there is necrosis over here. Yeah, and this is in the center. Okay. So what kind, the chat box is rife with what kind of necrosis it is. So come on, Kinjal, what kind of necrosis? First you describe it. Describe this necrosis. Describe it. Are you there, Kinjal? Has Kinjal disappeared? Are you there, Kinjal?
Yes, ma'am. Yes, ma'am.
Then please say yes. Don't sit quiet. How do I know whether your network has gone or whatever? All right. Say yes. Now come on. What kind of necrosis are you seeing? Just describe this whole thing, right? You're seeing a picture. So what are you seeing? Come on, Kinjal.
Central paler.
You see what do you see?
Centrally paler.
Centrally what? Paler.
Yes, ma'am.
Centrally paler. So this, according to you, that I'm seeing over here is pale. This part. That's what you're saying?
Yes, ma'am.
Oh, really? So Kinjal thinks that this is pale. Do you think it's pale, Kinjal? Huh? Do you think it's pale? So what do you think this part is over here? It's pale? You're going to describe this as pale? You're going to describe this place over here as pale? What do you describe it as, Kinjal?
Actually, it's a pink Due to
Pinkish.
calcification.
Are you seeing this as pink? This you're seeing as pink. This
Centrally.
thing which looks white is pink. To me,
Ma'am,
it's white. So why are you calling it pale? It's white, no? Kinjal?
Okay.
Ah, okay. So now, come on, Tinu. Is Kinjal right when she says that it is pale? What? Is Kinjal right when she says that it is pale? No, ma'am. All right. So then what should she have said? What should she have said?
Empty space.
Empty space. Yes. All right. Very good. Do you think, Tinu, that empty space is diagnostic of this kind of necrosis? Or is it just an empty space?
It's just an empty space
Okay. So why do you think there is an empty space there?
because of the dead cells.
Because of the
The
dead
central
cells.
nerves.
So what happened to the dead cells? They should be there, no? There's so many dead cells. Yeah, look at the number of dead cells. All of these are dead cells, but they're not an empty space. Yeah? So what happened? Why is there an empty space? Huh?
During sectioning.
Ah, so something fell out of that, right? Yes. So there was something there and it fell out. Kinjal, there was something there and it fell out. And what fell out? You see this stuff, Kinjal? What is this? This blue thing over here.
Ma'am,
What is it, Kinjal?
calcification.
What?
Calcification, ma'am.
Calcification. Yes. So what you had to say was in the center there was calcification. That calcification, part of the calcification has fallen out. Then what? Around the periphery of there is calcification around the periphery. What is there?
Necrosis.
Necrosis, yes. Yeah. And can you describe this? This necrosis? What? What do you see?
Comedo necrosis with calcification and fibrinoid necrosis.
Fibrinoid necrosis. Why are you calling it fibrinoid? Does it look like fibrin to you? Yeah. Do you know what is the color of fibrin?
Yes, ma'am. Pink.
What is the color of fibrin?
Pink, ma'am.
Pink. Now here I have on the first thing. That's pink. So therefore it is fibrin. Yeah, there are lots of pink things all over. Is that all fibrin? Kinjal, is it fibrin? So what is fibrin? You see something over here that is bright orange. Yes, forming a kind of network. That is fibrin. Fibrin is something that its precursor is fibrinogen. And when fibrinogen comes in contact with some kind of tissue fluid or something else, it undergoes, it becomes fibrin. And what is fibrin? It has got fibers, no? Thin fibers. My God, if you guys, that's why so often what is fibrin is called necrosis by students. Okay. You get a network. Fibrin is a network. Okay, so this is not fibrinoid. If I had to describe this, anybody else want to describe this? Mansi, come on, describe this. What are you seeing?
There is a central lumen, and that is most probably formed due to some artifact that there was calcium deposition, and while glossing, it has been removed.
All right,
So
very
we
good.
see a
But
central
describe the
lumen.
necrosis.
Then, ma'am, this is comedo necrosis, which,
Why is it called comedo?
ma'am, comedo means like a pore. So basically, the outline is preserved and the pore gets clogged by deposition of calcium or any
Yeah,
other
so
thing.
what is it? I know you're giving me all the story of what is comedo, but when you see comedo necrosis, it has to have a circular outline. Look at it.
Tumors, sir.
You'll never get a square, or you'll never get an outline that is irregular like this. Comedonecrosis always has a circular outline. Okay, all of it may be entirely necrotic, it may be centrally calcified or not centrally calcified, but you have a very well defined circular outline of tumor, which has a central area, also circular outline, which is necrotic. Okay, so that's why you have a duct, and this is a duct. Yes, if it is a smaller thing, you would call it a tube. And where do you get comedonecrosis? Everybody tells you it is like a toothpaste tube. Okay, if you had a round toothpaste tube today, most of our tubes are not round. Okay, but many of your ointment tubes are round, and then they have a little nozzle, and you squeeze that tube, and out comes this little thick viscid material. So this is fanciful. It's fanciful when you see it in histology, but if you're seeing it on gross, you will see comedonecrosis on gross. You will see all these little openings, okay? And in those openings, if you squeeze that gross tumor, you'll see, like you get, if you're squeezing acne, you know how that little pus point comes out? Yeah, that's how you will see it when you see it on a gross examination. Very good. So that is comedonecrosis. Excellent. So we have geographic necrosis. We have comedonecrosis. Yes, and comedonecrosis can be seen in benign ductal conditions in which you have the duct filled with a secretion. Okay, so you call it, it's not truly necrotic. There you have a secretion. Here it is actually necrotic tumor cells. Now, what would you call this on this side now? Of course, it is necrotic. You can see no nuclei in any of this. Can anybody identify this, what this is? Can you identify it? Anybody will identify it?
Coagulative
Necrosis.
It is what?
Coagulative
necrosis.
Coagulative necrosis. What organ is showing coagulative necrosis? Ambika, what organ is this?
TB.
What? What did you say, Ambika?
No, ma'am, I didn't say anything.
All right, then who said TB?
Mummy.
What organ has undergone coagulative necrosis? Because what is coagulative?
Any solid organ can go under.
Thank you very much. I'm asking you, what organ is this? What organ is this? Somebody is saying liver. Somebody is saying kidney. Somebody is saying infarction. Yes, there is somebody called SZ who has got the right answer. Some Dr. Kumar says it's a solid organ. Thank you. But what organ is this? Huh? Nobody can identify it? You think it's the liver? A liver looks like this?
No, ma'am.
No, ma'am. So think about it. What does it have? Somebody who said kidney. Yeah, notice that these things are all bent and they are tubular. So what other organ has got tubules besides the kidney?
testis.
Testis. Yes. This is an infarcted testis. Okay, and you can see that there is hemorrhage. It's a hemorrhagic infarct due to torsion of the testis. So this is coagulative necrosis with due to hemorrhagic venous infarction, because when you have torsion, the first thing that gets blocked is the veins, and the blood is still coming in through the arteries, and that's why you get congestion and hemorrhage. Okay, very good. Patterns of necrosis. Now, There is no such thing, and you will not find it in any of your textbooks. Okay, classification of major patterns of growth, and nobody's going to ask you such a question. So please don't sit down there and take notes. Just look at the stuff that we're going to see and pay attention to what we are going to say. All right, you know that growth patterns can be solid. So like just like you have solid organs, you have cystic organs, you can have solid patterns of growth, you can have cystic patterns. And there are some things that look cystic but are not cystic. They are pseudocystic. And of course, you can have mixed. There are other terms that we use for patterns. Circumscribed, encapsulated. So something that has got some very defined borders is circumscribed. Encapsulated means there is actually a fibrous capsule around it. So it may be fully encapsulated, partially encapsulated. Then if it's neither circumscribed nor encapsulated, then comes this term of infiltrative or invasive. It means the same thing. And there are two kinds of patterns of infiltrative patterns of growth. Okay, one is destructive and the other is permeative. You may call it non-destructive. Okay, and then of course you have erosive or expansive patterns of growth. Okay, then there are words that we use like nodular, lobular, radiate, sheet-like, polypoid, and ulcerative. So now let us see what these look like. Okay, now here we are. Who hasn't had a chance yet? I think I've asked everybody, but let's go to Ishita. Ishita, here you see, now I described a lot of things. Will you tell me, what would you say, describe this tumor in, I'm not asking you to look at the cells because this is at low power. I don't want a description of cells. I want you to describe, here we had all these terms now, okay? Nodular, lobular, radiate, encapsulated, all sorts, solid, cystic, etc. Now you have to describe this, this at low power. You're describing a pattern. What will you say? And there are people who are writing sensible things in the chat box.
Ma'am, the soft tissue tumor shown in the
Yes.
first picture
Yes.
is a no, solid pattern of growth
Very
with
good.
well
solid.
circumscribed and
Yes.
encapsulated.
Encapsulated. Excellent, Ishita. Then, is that all?
Ma'am, the pattern of growth here, it is nodular pattern, I think.
Nodular. Very good, Ishita. You have pale nodules in this tumor. You can see that. All right. So, yes, this is so. All right. Now, somebody else, Kiran, can you tell me about the lymph node? Ishita did an excellent job. Well done, Ishita. Come on. Lymph node. What are you seeing over here? Kiran.
We can see
Yes, Kiran?
follicular
Follicular. Yes.
structures,
Follicular. Excellent. Yes.
which have
So now Ishita did such a good job. She said it was solid, it was, circumscribed, encapsulated, nodular. So what do you want to say?
I can see
Ma'am, can we say in this, because this is in high power, we cannot, we
This
have
is not
to
high
see
power
this
at all. Not at all.
But-
You can see individual lymphocytes. So
No,
whoever
but
said
outer
that this is in
structure-
high power, it's not in high power. This is a low power examination. Who said that this was in high power? 1 minute. Whose voice was that?
Me, Ishita.
Ishita.
Ma'am, I thought this is in not
How
scanner
can you
view.
think
We
it
cannot
is in
see
high
this
power,
in
Ishita? Huh?
Ma'am, because the outer structure, is it capsulated or not capsulated, we cannot see with
That's
this.
all right. You may not see a capsule, but you can say something about this. Yes, Kiran? Yeah. No, okay. Come on, Ankita, what would you want to say?
Ma'am, from what I can see, it is circumscribed structure, solid, and nodules
You
are
don't know
there
that it
with
is circumscribed. Just because it says it's a lymph node, it may not be circumscribed. What can you see
solid.
here? We're looking for growth patterns.
Ma'am, nodules.
Ma'am, follicular pattern
Solid
of
or
growth.
cystic? Is it solid or cystic?
It
Solid.
is solid.
Arey,
Solid.
so it took you so long, somebody to say it is solid. It is solid and what?
Nodular.
Nodular or follicular, yes.
Follicular
Because
pattern.
it's a lymph node, we would say it is follicular. Otherwise, it is nodular, no? Yes, because we know it's a
Separated by
lymph node,
septum.
you would say it is. All right, so let's see. This is solid, encapsulated, and nodular. Yes, this is
Not effaced follicle.
this one. Now, what about this? This one is nodular. Yes, it's solid and it is nodular. We may use the term follicular because we know it is a lymph node. Very good. And people are getting the hang of it. That's excellent. Now, what is a nodule? Everybody said nodular, nodular. Okay, but when I ask what is a nodule, most often I don't get an answer. Okay, a nodule, and I have put it up over here, all nodules have to be large. If you have a small little thing, you can't call it a nodule. Okay, have to be large, and they have an arc at the edge. Now, what do we mean by an arc? Part of a circle, right? So see, all these have somewhere in the nodule an arc. Some of them are perfectly circular, but all don't have to be. See, this is a nodule. So somewhere in that nodule, and you can see them here, there's lots of little nodules. You may say finely nodular if you want to, but by and large, this is the definition of a nodule. Okay, it must have an arc at the surface. It's circumscribed, it has to be, and that circumscription has an arc somewhere in its surface. All right, good. Now, who's going to do the next thing? Tinu, come on. These two are one, these two are another. So come on. Anyway, what is the major growth pattern that you're seeing over here? Here you can see that there is squamous epithelium, okay? And you're seeing that. A little higher power, and you see the squamous epithelium here, and you're seeing this. Okay, come on, Tino.
Cystic.
Cystic, very good. This is a cystic. How do you know it's not pseudocystic? Why are you saying that it is cystic? So how do you define a cystic pattern of growth or a cyst? Come on, Tino, how do you define a cyst? Lined by, yes?
Flattened cells.
Lined by flattened cells. Okay. So, what do you think the pseudocyst of the pancreas is? It is lined by what? Flattened cells, right? But what are those flattened cells that line a pseudocyst? What?
Epithelial line.
Epithelial line.
So a pseudocyst is lined by epithelium? No. What is lined by an epithelium?
Cuboid.
What? Everybody is saying lining, lining. So I want to know what the lining of a true cyst is. And what is the lining of a pseudocyst? What? Somebody said fibrous. So we have to
forms a layer.
Pseudocyst lined by fibrous tissue or any granulation
So
tissue.
here we have cystic structures in a subepithelial position. Yeah. These are cystic epithelial structures. Okay. So what is a cyst? Okay. A true cyst, okay, has an inner lining of cells forming a definitive layer or layers. Okay. Now that definitive, you can get a cyst, which means that it is not it's just not just stroma. There must be a definitive layer. So you can get a mesothelial cyst, you can get an epithelial cyst, you can get an endothelial cyst. Yes, you can get a cyst in the brain. Yes, and what is that? You can get a cyst of what is the lining there? You can get an ependymal cyst, right? You can get a choroid plexus cyst. They don't have to be epithelial, but there is a thelium. And you know what Dr. Siddharth told you. This word thelium. Thelium means a layer. You have, yes, epithelium means an external layer. Endothelium means it is an internal layer. Yes, you have mesothelium, which means it's neither an internal layer, and we have just used these terms now. Endothelium means it lines blood vessels and lymph vessels. This is by usage. Epithelium means it is an external layer. So whether it is in the gut or it is on the surface of the skin, somewhere it must make a connection with the outer lining. Okay, you take the mucosa. It may look like it's inside, but if you go along the mucosa, ultimately you will come out onto the skin, no? Because it's all connected. Very good. And of course, as I said, you have mesothelium, and then you have the choroid plexus, and you have the ependymal lining that is present over there. So it must have an inner lining. Okay, very good. Now tell me, this is also cystic, right? What is it, a true cyst or not a true cyst? Come on, Manasvi.
This is not a true cyst, ma'am.
It is not, or it is? What?
Not, ma'am.
Not. Why is it not a true cyst?
No epithelial lining, ma'am.
Yes, because this is a solid tumor. It is a tumor. It's the same tumor seen on both sides. Okay, it's a solid tumor where bits of the tumor have fallen out, meaning this tumor is forming cysts, and these are not true cysts. They are just like a leiomyoma might become a fibroid, may become cystic. Okay, that means it collects fluid within that solid tumor. And when it collects fluid in that solid tumor, all the solid areas are pushed apart by that fluid. Sometimes the solid areas just fall out into that cystic fluid. Okay, and this fluid is actually in the stroma. So all of this is pseudocystic. It can be, here you see the solid nature of this tumor, where you are getting fluid accumulation, and that fluid is accumulating in the stroma and is producing a pseudocystic architecture, as a growth pattern in this tumor. Is everybody got this pseudocystic thing? Yeah, very good. You see that in the thyroid. You see it in lots of solid tumors. Fibroid. This happens to be a SPEN. That is a solid pseudocystic papillary neoplasm of the pancreas. Okay, so this is pseudocystic, and it happens to be encapsulated. All right. Now, what is this pattern of growth that you're seeing on the left-hand side over here? Come on, Mansi.
This might be a cribriform pattern.
Cribriform pattern. Acha? What is this pattern that you are seeing here? Cribriform. What is cribriform? You're seeing the things that you can hardly see.
Yes, ma'am.
What is
The sieve line.
overall pattern of this major pattern of growth? What would you call it?
This
Is
might
it
be a
fluid
radiating
pattern?
pattern.
Somebody saying infiltrative. So what is your take?
It is radiative
Yes,
pattern.
it is an infiltrative tumor. It happens to be a breast tumor, which is got an cribriform pattern of growth. So but it is infiltrative. Okay. But this is infiltrative, and I told you there are two kinds of infiltrative pattern. Yeah. What are the two kinds of infiltrative pattern?
Destructive and non-destructive.
Yes, destructive and permeative. So which one is this? Infiltrative, destructive. Yeah, it's destroyed. You saw there should have been fat right over there.
Yes, ma'am.
This is breast. Fat is destroyed. So it's infiltrative, destructive. Now,
Yes,
Mansi,
ma'am.
what is this?
Ma'am, this is cribriform pattern.
This is cribriform. Cribriform. What are these spaces, please?
Microcystic spaces.
Microcystic spaces.
Or fat.
This is fat. And there is something that is infiltrating between fat and leaving the fat structure absolutely intact. So what do we call this?
Permeative.
So yes, it is infiltrative. Now this happens to be a lymphoma that is infiltrating fat, but it could have well been inflammation that is going in between fat. Please, this is not cribriform. And it was well explained to you what was cribriform the last time. We will come to cribriform somewhere down the line. So this is infiltrative permeative. Now, what would you say about number 3? Come on, Ambika, what is this?
Thick lining of skin, hyperplastic epithelium, hyperplastic.
You think it's skin? Why do you think it's skin? Huh? It isn't skin. This is not skin. This is mucosa. Yeah, and you've got a flat thing on top. And what do you have? Somebody saying papillary. No papillary structure can be flat on top. Okay. Yes. Somebody is saying pushing border. Yes. Yes. So this is pushing or erosive. Okay. So this is erosive or expansile. So now see, these are things that you see. It is not about big diagnoses that we're making, but using this now, what you're seeing over here would be seen in a verrucous carcinoma. When I see this erosive expansile lesion, with the squamous mucosa, the thought that's coming to me is that this is a verrucous carcinoma. When I see this kind of infiltrative permeative thing, I begin to think inflammation or lymphoma. And here is, yes, any kind of infiltrative tumor may do the same. Excellent. Now, all these 3 are the breast. Come on. And they are all showing the same pattern. What is this pattern? Come on, anybody. Now don't make me scream out to who's the next thing. Ishita, come on. What is this pattern? Just describe it.
Gland.
Ma'am, is
What? What did you say? Plasma?
ma'am, is it
It
radiating?
is
Is it radiating?
radiating. See, from a central area of, in this case, collagen, here also collagen, but a little bit more cellular over here. You can see how this tumor is radiating out. Okay. Some people might mistake it for an infiltrative pattern, okay? But it is not. This is a classical radiating pattern, and all these three are radial scars. Now, why is it not an infiltrating pattern? Because I do not have little groups of cells, as you saw in this previous thing, out into this producing a desmoplastic stroma. What have I got here? I have got groups of cells, and these are really ducts. It is the ducts that are radiating out from the center. Yeah, there is an epithelial proliferation within the ducts, but it's not individual cells that are going out into the stroma and producing a desmoplastic or a fibrous stroma. So this is a radiating pattern. It's called a radial scar. Okay, now, who was next? Kiran. Kiran, what is this pattern?
We can see tumor cells in neck arranged.
Sorry, what do you see? Tumor cells
Nest.
in nests. Acha. So you think this is a nested pattern? Okay, Ankita.
Ma'am, lobular, multiple
Lobular pattern. Excellent. Lots of people are saying lobular over there. Okay. Why is it a lobular pattern? Come on. I think it was Ankita. Yes. Ankita, why do we call this lobular? And will you please tell Kiran why, or this is not nested?
Ma'am, because lobule, it should have something from which it is appearing like it is originating from, if I can just note it, like if we can draw a stalk or something like that, I can just show on the diagram. These three lobes seem to be appearing from some
Very
common
good. Come
connection.
on, somebody asked. Who asked for a thing? I
Like
hope I
this.
didn't.
Ma'am, I
Very
asked
good.
first.
Come on, draw it.
Yes, ma'am. If we see, we can see this green one is the
green
this
one.
one.
Where is the green
Yes,
one? I
ma'am.
can't see.
See, this is then this one lobule, then this one, and this one.
Yeah, but I
So
can't
it
see
appears to
anything.
be.
Where anybody can see her green one?
Ma'am, I have
No,
drawn
ma'am.
on the.
No, you took the first pen. Please take the second pen.
Okay, sorry, ma'am. Sorry. Yes, ma'am. Ma'am, is it visible now?
No, no. But anyway, I think you know what. Yeah, you know what? What she was probably trying to draw is something like this. Yes.
Yes,
See?
yes, ma'am. And it appears to be coming from some common
Yes.
connection, like stalk, like something. Yes, ma'am. Yes.
Absolutely.
And
So
below
there
the stalk.
is
Yes, ma'am.
an area where all these things join up. Okay. So this is called lobular. Okay. See, you look at it over here. This is a more, this is how, if you had seen this at low power, this is what you would have seen. Okay. All of them are radiating towards or radiating away from an area, and this is called a lobular. Okay, you see, I've drawn it over there. It's called, this is a lobular hemangium. Okay, also known as a pyogenic granulome. I know these are somewhat confusing. You have to remember it. Array, why don't we call this radiate? Well, radiate and lobular are more or less similar, except that we call this lobular because all of these things look exactly the same, just as you would see in a lobe. And a lobule is a small lobe. So like in the lung, you have the hilum, and from the hilum, you get these circumscribed areas which have got a very clean. So you see, the whether you take the lung or you take the liver, you can make out where the left lobe ends and the right lobe begins. Similarly, in the lung, and that is why we call something lobular. This is very different. See, that's what it means, exhibiting a lobe-like morphology. but it is not the same word where we use this term lobular carcinoma in situ. Okay, this is not a lobular pattern of growth. This is the tumor affecting a lobule, one single, or in other areas, multiple lobules. So this is not the same way in which we use this term lobular. Yes, lobular is an adjective. When you say lobular carcinoma in situ or lobular carcinoma infiltrative, it means it has arisen within a lobule. That's a different way of using the term lobular. Okay, I'm sorry, but this is English. Okay, somebody who's going to say what is this pattern? Now, Tinu, what is this pattern and what's that pattern? Come on, Tinu. Are you there?
Papillary.
Mhm.
Ma'am, papillary.
Now, 1 minute. There
Papillary
is no word like spindeloid and papilloid. Okay? There is a word like epithelioid, but there is no word. There is endometrioid, but there is no word papilloroid and spindloid. It makes my blood boil when I hear that. Okay? So never use that term. It's either spindle or papillary. There is no papilloroid. And that means, my dear Tinu, that you don't know whether you want to call it papillary or not. And therefore, you have invented this term papilloroid. Yes, people in the chat box are saying. Yes. See, can you
Polypoid.
see that here is an epithelium? Yes. There's an epithelium on the outside.
Polypoid, yes, ma'am.
Polypoid, absolutely. It is,
Polypoid.
yeah, it is like it's a protuberance.
Protrusion.
Yes, protrusion, which is usually covered by an epithelium of one sort or another. Okay, very good. And what is this on the other side?
Ulcerate.
Ulcerated.
Ulcer.
Excellent. Very good. Now, who answered that? Tinu, you answered that?
Ma'am.
Who answered? Ulcerated. I is who?
Tinu.
Tinu. Very good. Now, will you please define an ulcer, Tinu? Define an ulcer.
The lining is gone.
Sorry?
The lining.
Lining is gone. That's an ulcer. What is an ulcer?
The breach.
Yes. Yeah, you have to think, no? So what is it? What are you saying? And people in the chat box are saying, breach in the continuity of a lining epithelium, right?
Yes.
Yes, Tinu?
Yes, ma'am.
Oh, okay. So now, Tinu, you're going to answer me. Every time a surgeon incises the abdominal skin, he's creating an ulcer. Yeah, the surgeon is making an ulcer because he's made a breach, right? What? Yeah, somebody is got the idea and they are saying things in the chat.
Inflammatory granulation, presence of
Has to be
granulation
inflammatory.
tissue.
Yeah, do you think so? All right, I'll give you another
Granulation
example.
tissue must be present.
Granulation tissue must be there. Okay. I fall down on the, on the pavement and I have got an abrasion on my knee. Is that an ulcer? You know what is an abrasion? Yeah, the skin has gone. Maybe the entire skin has gone. And then, there's bleeding and stuff over there. So is that an ulcer, Tinu?
It should be chronic.
It should
not be
chronic.
acute.
Yeah, so it doesn't have to be chronic, but something that is acute, an acute breach in the continuity of a lining epithelium of an epithelium cannot be defined as an ulcer. Okay, so when the surgeon incises the skin, I fall down and I graze, or I get an abrasion on my knee. And don't tell me that there is no inflammation. There is inflammation. Because the moment the surgeon puts a knife on the skin, of course that skin is inflamed. It's not, what is the definition of inflammation, Tinu? What is the definition of inflammation? What?
There will be
Is? It's a response to injury, no?
response.
Yes, the cellular and tissue response to injury. So, yes, if somebody puts a knife on my skin and incises it, of course there will be inflammation. So it is not about inflammation. It is about the acuteness of the breach. If something is breached acutely, there is no ulcer, okay? If that breach does not heal, so you can get, if the surgeon does not stitch that skin and ultimately you get a non-healing wound, it becomes an ulcer, okay? If it is on the skin. So there has to be a certain degree or time over which that breach has occurred. Okay, there is a time. I can't say that it is entirely chronic, but there is some time and it is not acute. That is what an ulcer is. Okay, so this is ulcerative. Good. Now, how do we describe an ulcer? We have a floor, we have a base, and we have an edge. Okay, over here you can call it edge, you can call it a margin, whatever you want to call it. Okay, now this is the floor of the ulcer. And what is the floor? It is that portion of the ulcer that you can see if you're looking at it from above. So that's the floor. This is the base. So you can't see it when you're looking at it from above. It is what is is seen at the bottom of that ulcer, and it is the part between the normal and the abnormal portion of the ulcer where you get repair, maybe regeneration, maybe granulation tissue. It depends on what is the age of that particular ulcer. So this is the base, okay, over here. Then there is some normal tissue over here, which you can't see in this particular case. And you see this. This actually is the stomach, okay? So you see the stomach mucosa, and this is an edge. And this edge is undermined. Can you see? There is an undermining of the edge over here. Our ulcer over here did not have an undermined edge. Okay, the edge was sharp in this case. Here you can see that here is this epithelium, and the ulcer has undermined that epithelium so that the epithelium looks like it is overhanging this edge of the ulcer. This is the floor, and this we'll see it once again as to what this is. All right, so we had major patterns, and now we have sub patterns. Huh? And the sub patterns, as I said, may be monomorphic, pleomorphic, polymorphic, etc. There may be other patterns which are epithelioid, mesenchymal, bi and triphasic, which means both epithelial and mesenchymal, or more than one kind of mesenchymal, round cell, okay? Now, the major pattern for all of these could be solid, could be cystic, could be sheet-like, okay? But individually, there are sub-patterns, and these could be the sub-patterns. Now, how will you define an epithelioid pattern? An epithelioid pattern is called epithelioid because it looks like an epithelium. And it is, what does an epithelium look like to you? It is cohesive. All the cells stick to one another. They are usually flat, and the cells are usually cuboidal or columnar. It's very, very uncommon to get cohesion and flatness unless the cells are cuboidal or columnar. What is mesenchymal? Well, mesenchymal pattern is when the cells are spindle or stellate and they have a loose arrangement because they are not tightly packed together, all right? They may or may not have matrix formation. So there is less cohesion or no cohesion at all in a mesenchymal pattern. Now, please mark my words, it's a pattern. There are mesenchymal tumors that may show an epithelioid pattern, and there are epithelioid and epithelial tumors that can show you a mesenchymal pattern. And we all know that there is such a thing as a sarcomatoid carcinoma. And we all know that there are epithelioid smooth muscle tumors. There are epithelioid sarcomas. So they are not of epithelial origin, but they have an epithelioid pattern. So there is a difference between saying that something is an epithelioid of epithelial origin or mesenchymal origin, but having an epithelioid pattern or a mesenchymal pattern. If there are any questions about this, please let me know now or later. Then we know about these round cells and so forth. These are epithelioid plus mesenchymal plus round cell, or multiple mesenchymal patterns, etc. And you have round cell, which is small blue cells, little cytoplasm, and prone to crushing. So these are some patterns that you get. Any of them can be monomorphic or pleomorphic. Mesenchymal ones can be quite often pleomorphic, but they can be monomorphic as well. So we have to look at all these and make our descriptions, because these descriptions are important. Now here, we're looking at sub-patterns, okay? What would you call this? Come on, anybody, you can write it in the chat box.
Monomorphic population of cells.
Very good. This is uniform, it's monomorphic. Little variation in size and shape of the cytoplasm and nuclei. But the major pattern, I said this is a sub-pattern. What would be the major pattern in this case? Anybody? Come
Solid
on.
pattern of growth.
Solid.
Solid is yes, but what? Just solid?
Flat sheet.
Sheet. So the major pattern is a sheet, because there are no other patterns except for this. It's like patternless. It is monomorphic and patternless, and therefore it is a sheet. What would you say about this thing on the right side? Obviously, this is monomorphic.
Pleomorphic.
That is pleomorphic. And pleomorphism, please, is not some minor variation in nuclear or cytoplasmic shape or size or anything. It is marked variation in size and shape of the cytoplasm and the nuclei. It may even be in the tinctorial properties, that means the color. It may be very dark in some and very pale in some areas. So that is what pleomorphism is all about. Now here is some other sub-patterns, okay? I said polymorphic and polymorphous. Here is a solid tumor. Solid is the main pattern, okay? And this tumor is got more than one pattern. Now we use this term polymorphic. Now everybody, there are lots of people in the audience will say, oh, this is a pleomorphic adenoma. Yes, it is. We use this term pleomorphic adenoma, but it's a misnomer. This is pleomorphism, what I showed you. Yes, marked variation in size and shape. For whatever reasons, the word pleomorphic was used for this. The words poly and pleo mean more or less the same, but it's in the usage that we should distinguish between the two. This is pleomorphic. as a pattern, as a description, this should have been called polymorphic. Okay. Now the words polymorphic and polymorphous also mean the same. Many different forms, because morphic means appearance or form. So there are many different forms. Now this polymorphic is not just cell forms, but tissue form. So we have stroma, there is cartilage, there are tubules, there are epithelial cells, there are myoepithelial cells. You may get bone formation, hyaline. So this tumor has many different forms, and the word that we should have used, but we don't, is the word polymorphic, but it's called pleomorphic. Okay, polymorphous. Now that's used when there are many different cell types. Okay, so polymorphic means multiple different patterns and tissues. Sorry. Polymorphous, it's, as I said, these words are just, they sound so much similar, but they are used differently, is multiple different cell types. And this is in Hodgkin or some other lymphoma in which you're seeing eosinophils and lymphocytes and histiocytes and plasma cells. So this is a polymorphous tumor. Okay, good. Now, here are some other major subpatterns. Okay, come on now, what would you call this and this and this? It's very easy. What is this pattern? I hope you're having fun, because I enjoy this kind of thing. It's like a quiz. Chalo, who's going to answer this now? Ambika, what is this pattern? You see tumor cells, okay, over
Yes,
here.
ma'am.
And they're growing in what pattern?
From a center core, they're like extending outward, like this.
Oh, from a center core, they're extending outward. You know some kind of pattern that does it? Now, you have to describe in your description, you're seeing this tumor composed of cuboidal cells. Yeah, some cells are
Epithelioid.
Epithelioid pattern. Excellent. This is an epithelioid.
Epithelioid pattern.
Okay. What is the next pattern?
Mesenchymal pattern.
I'm talking about
Mesenchymal.
sub-patterns, huh? The major pattern is
Mesenchymal.
solid and infiltrative. Yes. What is it?
Mesenchymal pattern.
Mesenchymal. Yes. This is mesenchymal and infiltrative. Okay. This is a desmoid tumor. It doesn't matter to you what it is, but it's a desmoid tumor. Okay. And what is the third pattern? Come on. What is it? Shout loudly.
Round cell.
Small round
Round cell, small blue cell, round cell. See, when I have a tumor, to me, when I'm looking at it, I look at its cells, and the next thing I want to know, I have to describe this tumor. I look at that, I'm not just going to say, oh, it's made out of epithelial, of cuboidal cells. I want to say it is an epithelioid looking tumor. This I want to say has got a mesenchymal look. That I want to say is small blue cell, because once I have identified this major subpattern, then I can look to see what are the possible tumors that will cause this pattern. Now, tell me, what do you think this epithelioid pattern is? It's got cuboidal cells. Do you think it's a carcinoma? Or because that is an epithelioid tumor? What? Funnily, this is an epithelioid pattern, but it is a gastrointestinal stromal tumor, which is truly a mesenchymal tumor. Yes, but it is growing in an epithelioid pattern.
Epithelioid.
Yes, so please understand the difference between a pattern and the histogenesis. The histogenesis of this tumor is from the interstitial cells of Cajal. Never mind if you don't understand what that is, but it is the pacemaker cells, which are not epithelial cells of the gut. Okay, it is a cell that belongs to the mesenchymal. They're neither epithelial nor ectodermal or endodermal. They're squarely mesenchymal, and they are giving you an epithelioid pattern of growth. Here, this is a mesenchymal pattern. You can see the spindle. It's infiltrating skeletal muscle. So it is mesenchymal. In this case, you would say non-destructive, but there may be areas in this tumor where the skeletal muscle has been destroyed. But here it is permeative. And that is a small blue cell tumor. Now, what is that small blue cell tumor is important. In this case, this is a small cell carcinoma. All right, if this were a child, this is not a diagnosis I would have made. So you see, we're talking now about context. This in a child could very well have been a Ewing sarcoma. In an adult, I have other things to think about. And this is a small cell carcinoma. Do you get now what the meaning of all of these things are, including context? Okay, so a small cell tumor in a child, you would never ever think of a small cell carcinoma. It does not occur. It could be it could be a lymphoma, it could be a Ewing sarcoma, it could be rhabdomyosarcoma, it could be any other small blue cell tumor. But in an adult, it's unlikely to be a rhabdomyosarcoma or anything. It's more likely to be a small cell carcinoma. All right, so this is context. Age gave you the context here. Okay, what is this? We've said it. Epithelial, mesenchymal, biphasic. And this is a fibroadenoma. Mesenchymal and triphasic. Why? Because I have got three different, yes, in the tumor there is fat, there is this fibrous tissue, and there's loose mesenchymal tissue over here. So this happens to be an infantile hamartoma. It's a hamartoma of infancy. And this is I'm sorry, but I don't think I can see this well, so you may not be able to see it well. But there is an epithelial component here and here and here, okay? And this is mesenchymal and epithelial. This is a carcinosarcoma. The pattern is biphasic. Never mind what the diagnosis is, but you should be able to recognize patterns and write your description such. You look at this, say, and you will say this is a biphasic tumor. You will say biphasic tumor in the, or you might say fibroepithelial tumor in the breast, which is the term that we use for fibroadenomas and Pillodi's tumors. Okay, so fibroadenoma, hamartoma of infancy, and a carcinosarcoma. Now, with epithelial and epithelioid patterns, okay, there are terms that we use. I showed you some sheet-like ones, etc. But there are terms. There are patterns with spaces, and those spaces are glandular, ductal or ductular, tubular, acinar, alveolar, follicular, cribriform, adenoid, and comedo. So there are, look at the number of terms that we have for epithelial or epithelioid patterns with spaces. Then we have the same without spaces. And when you don't have spaces, then you can have sheets, morules, nests and islands, squamous, squamoid, epidermoid, stratified, pseudostratified, papillary, villous, pseudopapillary, rows, cords, and trabeculae. So, you know, everything, if you sit and think about it, we use terms, but we have to understand what it is. All of these are terms that we use for epithelial and epithelioid patterns, okay? So what is a gland? Come on, anybody will tell me what is a gland? Come on, who's going to tell me what is a gland? Ambika, what is a gland? How does it differ from a duct or a tubule or an acinus or what?
Gland is the site where the secretions are produced. And duct is
Yes,
the pathway
so
from
a
which it
gland,
is.
very good. A gland must have a secretory component. Otherwise, you can't call it a gland. And I am absolutely have no patience with people who talk about, describing adenocarcinoma in the breast or, whatever, and saying it is full of glands. There are no glands in the breast, okay? Because in the breast, except when a woman is lactating, there are no secretory components in the breast, okay? What you get are ducts, ductules, tubules in the breast, okay? So when you are talking, yes, you get glands in the colon, you get glands in the stomach, in the pancreas, you do not get glands in the breast, okay? So please don't use the word. The same word adenocarcinoma is used for something that has glands as well as ducts. But when you're using a description, please do not mistake a gland for a duct, okay? So what is a duct? It is a conducting structure, okay? So it's long and it's narrow. A gland has a certain dimension. It could be round, it could be tubular, but it is secretory, okay? What's an acinus? Now, an acinus is also secretory, okay? But an acinus is the distal most secretory part of any structure. So it will be distal and it will have a blind end. So like the acini that you see in the pancreas, the acini that you see in the salivary gland, okay? What is a tubule? Tubular means like a tube. So same thing, like a duct it is again a conducting structure. What's an alveolus? Like the lung alveolus, okay? But before we go there, let's see this. Here is an acinus. These are acini, the distal most secretory structure which doesn't conduct anything, okay? So we don't use the word gland because once again, the entire salivary organization is a gland. So that is an anatomical gland. And within that anatomical gland, you have acini and you have ducts. And you have various different kinds of ducts. Here you have intercalated ducts and you have striated ducts, and then you have the ejaculatory ducts, etc. Okay, so now here is the colon, and the colon has glands, and these glands are secretory. They secrete, okay, and these glands are called tubular glands because they look like tubes. Okay, so a gland may be tubular, but it has to be secretory. There are many tubules that are not secretory. They're just conducting structures. So ductule, tubule are conducting. When you use the word tubular, you can use it for gland. Of course, you can use it for a tubular duct or a tubular ductule. Okay, all right. Now, what is an alveolus? An alveolus is something that is pouch-like and non-secretory, like the alveolus in the lung. You also have alveoli, which are the tooth sockets, and that's why you have the alveolar, portion of the mandible and the maxilla. You call it the alveolar process of the mandible and the alveolar process of the maxilla. You have the tooth sockets, and these tooth sockets are non-secretory and they are pouch-like. That's why they are called alveoli. Now you will say, what about alveolar soft part sarcoma? What about alveolar alveolar rhabdomyosarcoma?
Raptor.
Yes, actually, those are solid tumors, but they develop a little space in the center. They are non-secretory, okay? They are not secretory, they are not conducting. So what else are you going to call it? So that's the reason that they were fancifully, thought of as pouch-like structures, and they are called alveoli. Okay, they are not true alveoli, they are pseudo-alveoli, but the name has stuck. Very good. Now, what is follicular? See, these are follicles. Okay, you see lots of follicles over here. I'm not talking about this whole structure. This one is an encapsulated lesion. You can see that, which is composed of follicles. Okay, so this has a follicular pattern of growth. The entire thyroid has got a follicular pattern of growth. So what is it? It is spherical and it is closed. Okay, that's why you have follicles in the lymph node, which are solid. You have other spherical, so closed meaning a nice round structure. There is no opening to that. So as well as, where else will you get a follicle if it's not in the thyroid or in the lymph node? Anybody? You can write it in the chat box, or any of you can tell me. Come on, Ishita, where do you get a follicle otherwise? Oh, you get it in the ovary, no? Yes, so that is a fluid-filled follicle. This is a colloid-filled follicle. And the follicle that we get in the lymph node is a solid follicle, right? So now you have understood what is the meaning of the word follicle. It means that it is spherical and it is closed. Now the distal-most end of the hair structure is called a follicle because it is round and solid. That one has been called a follicle, although it does have a minute opening through which the hair actually comes through. Okay, now cribriform and adenoid, they're not the same at all. Cribriform means sieve-like, it's perforated, okay, and this is perforated. And so when something is perforated, and notice that the perforations are usually of the same size and extremely well demarcated. It's literally like a sieve where the holes are all of equal size, evenly spaced, and well circumscribed. Yeah, not only circumscribed, but they are round. They don't have any odd shapes, etc. So this is the meaning of the word cribriform. It means perforated, but all cribriform structures are not epithelial in origin. Some of them are glandular in origin or ductal in origin. They are sometimes pseudo, and these are called adenoid. Now, why do we call them adenoid? Because these structures are not lumina. Okay, if this were a cribriform structure like you get in the breast, in an intraductal carcinoma or an invasive cribriform tumor, like somebody noticed in that case, these would be lumina. And what is a lumen? A lumen is something that has an outer rim that is made of either epithelium or endothelium, okay, because an endothelial line structure also has a lumen. But what's there is, it is not in connection with the stroma. Okay, now this, if you see over here, is in connection with the stroma. Yes, exactly. And therefore, These are gland-like, non-epithelial secreting structures that have these look like they have this perforated structure, because this material that is over there is actually stromal material. It is matrix that is being produced there, and it is not a secretion or like when you have a lumen in the endothelium lining something which the endothelium doesn't secrete anything, but epithelia do secrete them. So these are not true lumens. Okay, now we'll forget that. All right, now what are the epithelial and epithelioid structures without spaces? We've already said that, right? Squamous, keratinizing squamous, and people sometimes refer to this as a pearl, and they refer to this as a pearl because if you take this out and you examine it, it'll have a pearly architect. You will look at, when you look at it, it does look like a pearl because that's what keratin looks like, waxy and pearly in nature. So this is keratinizing, and this is a non-keratinizing squamous, which is called epidermoid. And if you look carefully, you'll see the desmosomes. Can you see such a beautifully cut section in which you can see those little connections, bridges between individual cells, which are called desmosomes? Okay, so this is without spaces. Okay, here again, without spaces. This is what is called papillary or villous, and there is no difference, my friends, between what is papillary and what is villous. It is just by usage, it will be in all of them are finger-like. Okay, thin, long structures. Okay, sometimes we talk about broad papillae, and we'll show you some of them, but they must have a fibrovascular core. Okay, so there you are. A villus has a fibrovascular core, and this is papillae. They don't form spaces because these are all epithelial cells that are on the outside of the stroma. This is an intestinal villus, the small intestinal villus, and because this papillary structure resembles that villus, it is called villus architecture, which you get in colonic tumors, which we call villus adenomas, or sometimes even a villus carcinoma that is seen. Okay, here also you have things without spaces. This is just solid. These are not papillae. Okay, a lot of people mistake them for papillae, but they are not. Again, this is a pseudo-papillary structure. It's solid, but these are not, you know, what we saw here, stromal structures that go through these spaces that project into something. Okay, so they're narrow processes that project into a space or above a lining with a surface lining and a stromal core. This is not. It looks as if it has papillae, but it is actually nothing but stroma that is present in a very solid tumor. So this is pseudo papillary. A lot of people would say that this is papillary, but it is not. Okay, without spaces, what would you call this? Which is there on the left-hand side? This is a sheet. It's a sheet. Why? And it's a sheet which has got stroma dissecting between the sheet, because a sheet is a patternless arrangement. What is this? They're nests or islands. Very good, yes. Which are small or medium-sized groups of cells, all of the same type. That's very important. Separated from each other by distinct boundaries. An island is just a larger nest. Okay. Now you can't call these nodules They are not nodules because they are irregular. Do you notice that? Yeah. So, and they are small. One or two of them might have a little arc, but they are small or medium size. Nodules are large. Now, you might call this last one a nodule. Yes, it does have a nodular appearance. Look at that. Okay, but what is it? We call this a morule. It's used in a very distinctive kind of way. It is a nest of cells, often, not always, arranged in a concentric fashion amidst differently patterned cells. You see that? So yes, it might fit the definition of a nodule, but you see around it, you have other differently patterned cells. Look, these are glands. These are glands that are surrounding this particular structure over here, which happens to be a squamous morule in an endometrium. Okay, so that is what is a morule. See, over a period of time, don't try to mug up these definitions. Okay, just listen to them, and when you see them in books or you have to apply them, just look at them and think. There are some definitions, and how do we apply them? Okay, again, without spaces. What would you call this? Anybody? What would you call this? Kinjal has been very quiet. Come on, Kinjal. What pattern is this?
Trabeculae.
Trabeculae. The number one is trabeculae.
Chords.
Chord. There is a difference, my friends. And I know that people often mistake the two. This is a chord. What's the next one? That's a trabeculum. And so also is number 3. A row or a chord, single cells, usually cuboidal, arranged in a single row. Okay? A trabeculum is, as you were told, it's either a beam or a wall. Thick rows of cells, but could be non-cellular tissue. It doesn't have to be cells, okay? It could be cells or non-cellular tissue, which is like extracellular matrix, with an elongated arrangement like a beam or a long thin wall. So this, now, this is also a trabeculum, this is also a trabeculum, but this also has an organoid appearance. Now somebody asked that day, what is organoid? It's cells arranged in nests or trabeculae with nothing but a sinusoidal stroma. Nothing, okay? And you should know what is a sinusoid. A sinusoid is a vascular structure, whether it is lymphatic or endothelial, or a blood vessel, okay, containing blood. It has endothelial cells, but those endothelial cells do not have a basement membrane. So they're very porous. That is what a sinusoid is, lymphatic or blood vessel. So you see, there is nothing but this. Now, you might ask, why were they called organoids? Well, they were called organoids because people thought they resembled small little developing embryos, okay, which were just forming here. So they were called organoids. And that is a term that is often used in developmental biology also when you are trying to grow cells in vitro, okay? They come up like these little clusters of cells, and that term has been used over here. Okay. Now we come to some mesenchymal patterns, okay? And we have to hurry up to finish. Spindle cells may form any one of these patterns: a fascicle, a sheath, a herringbone, a storiform or cartwheel appearance, a palisade, hemangiopericytomatous pattern, or a plexiform pattern. You can also get in any other thing haphazardly arranged, or you can get a rosette. I'm not going to spend too much time on the rosette because I think Dr. Datta Gupta did a good. You can get myxoid, myxochondroid. Somebody said world and modular. Yeah, in the chat box we can answer that question. Bone and cartilaginous matrices, and collagenizing, either collagenized or no non-collagenizing patterns. Now look at these spindle cell patterns. So what would you call this pattern over here? And this pattern,
Fascicle.
and this pattern. Yes, the first one, you see, long cells, so only long cells, and spindle cells are long cells with long nuclei, all running parallel to one another, but parallel to the direction in which, so it's a bundle. And in that bundle is all the cells are running parallel to the bundle. But what I want to show you is that this is what a fascicle is. When you cut the fascicle transversely, see how they look. They don't look spindle anymore. So you have to do, this is a two-dimensional, what we are looking at is a two-dimensional flat face. And we have to build in our minds a three-dimensional structure. So I told you, pattern and structure. So this is the three-dimensional structure is where you have lots of fascicles that are going in different directions. What will you call this now? That's a fascicle. What's the next one?
Herringbone.
Yes, it's herringbone. Excellent. So you see this feather-like or herringbone, you have this isn't a spindle cell going like this. It is the spindle cells arranged so that they meet in the center. Okay, so that is herringbone. And what is this one? Somebody asked me the question at that time, whether a palisade or a picket fence is the same. Yes, it is the same. Okay, this is the direction. This is in which the bundle is running, and the elongated cells, whether they are columnar cells or they are spindle cells, they will lie perpendicular to the direction of that bundle. Okay, so there is perpendicular in the fascicle, there's perpendicular in the palisade, but the perpendicularity is different. This is perpendicular to the direction of the bundle. Here it is, parallel to the direction of the bundle. Here it is parallel, the cells are parallel to one another, but they are placed perpendicular to the direction of the bundle. Okay, so that's a palisade. Now, what do you have here? Everybody knows what it is on the left-hand side. Yes, come on. Ankita, what is this on the left? What pattern is it?
Staghorn pattern.
Hemangiopericytomatous pattern. See this antler horn?
Staghorn.
Yes.
Staghorn pattern.
Staghorn, the antlers of the stag. Okay, this thing that the stag has is an antler. So this is the staghorn pattern, or the way that the spindle cells are arranged around these branching vasculature. Okay, what's the next one?
Storyform pattern.
Storyform pattern.
Yes, storyform or cartwheel, and you can see that the cells are arranged in a world pattern. So this is correct. A world pattern is storyform. Okay, and this pattern that you're seeing over there, what would you say? And I think you will say, I don't know. And you would be right, because this is haphazard. The spindle cells are all in different, they don't show you any particular pattern, but they seem to be arranged. One is at odds at the other, some are perpendicular, some are not. Okay, so this is haphazard. Okay, now what is this pattern? And it's the same in both. It's the same. Yes, there is
World
a fascicle,
appearance.
you can see. No,
World.
it's not world. The world is each spindle cell is whirling. This is not what it is doing. There's a fascicle here. You can see That fascicle is whirling. Some of these, see this fascicle is going around like this. Some fascicle is going anti-clockwise. Some are being cut transversely. This is what is called a sheath. You see that? Fascicles of spindle cells arranged in a crisscross fashion forming a sheath. That's why when you cut it, again, that's the structure. A sheath is a structure. We are seeing this in 2 dimensions, and that's why it has this appearance. See all these sheaths, which is a bundle tied in the center, giving you this, this slanted and crisscross fashion. Okay, here you have some more spindle cell patterns. What is this? All of them are the same. Look at them.
Ma'am, is it sheaf only?
No, it is not a sheath. See, each of them is a circumscribed bundle. Can you see? Yeah, and they are intersecting with one another. Each is a bundle and it is intersecting with one another. But they all seem to be going in one direction. But they are, yes, somebody is saying, very good, plexiform in the chat box. See? That is what is a plexus. Look at that. That's a plexus. It's a ramifying leash of elongated bundles, in this case of cells, or of tubular structures, yeah, like nerves or vessels. So you can get a plexus of nerves, a plexus of vessels. And when you see that pattern in a tumor, you call it plexiform. Okay, that's what, like a cable which has an outer rim and have all these long tubular or long bundles that are present in it. Now I won't go into rosettes. I don't believe that there are true and false rosettes. For me, it doesn't exist. Okay, this is, but the types of rosettes are important. This is a homorite rosette, and everybody believes that it is true. A true rosette, sorry. Okay, and that is homorite. This is Simon Flexner, and that was Wintersteiner. And these homorite rosettes are made up of hairy projections from the cells towards the center of a group of cells. Here too you have the hairy projections, but they meet around an inner limiting membrane. So that is the Flexner, Wintersteiner, and people, the neuropathologists called it true rosettes. Okay, here is an ependymal rosette. Look at all these small little cells, and what they mean by true is that the rosettes are being formed by the cells themselves, not any other structure. Okay, so these little things which don't have necessarily a limiting membrane, but those are ependymal rosettes. Now, these structures over here, okay, seem to have a blood vessel in the center. Okay, so there are both true ependymal rosettes and perivascular ependymal rosettes. And sometimes people say they are false. I don't believe in all this true and false. Just recognize a rosette is a small flower or a rose. The word rose is used for any flower in many of these French and German and the European continental languages. Okay, now here is a rosette that is formed by cells. So you should call it a rosette. Okay, but this thing is not anything to do with neuropathology. This is a neuroendocrine tumor. And because it's a neuroendocrine tumor, it is not, it is of epithelial origin. It's called, they are called microglands. And now people say that they are not true rosettes. Now, that's why I told you, they are rosettes, and neuroendocrine tumors form rosettes. And I believe I would call them rosettes. Okay, so don't fight about these things. It's a structure that looks like a small flower, and that is what is a rosette. Whenever you use the term ETTE as a suffix, it means small. Okay, so rose and rosette. Okay. Mesenchymal matrices, this is myxoid. That is collagen, this is myxoid. Okay, you see it's bluish gray. This has got myxoid and something else and collagen. This has got collagen as well as calcifying osteoid. You can see that over there. But notice that collagen is light pink. So also is osteoid. It is not bright pink unless it becomes what we call hyaline. Okay, so since I'm not talking about tinctorial things today, I'm not going to go into it. Here, now, what is this matrix? Here you have cartilage and osteoid. What is this? This is osteoid. And what is this? This is woven bone. Okay, so these are the matrices that you see in tumors. Now here, this is both, this looks a little bit like cartilage. You see that over here. And here it looks a little bit more myxoid. And we talk about this in many tumors, but predominantly in a mixed tumor of the parotid gland, this is myxochondromatin. Okay, now come on, you will have to do some hard work. Now identify this pattern, thyroid tumor. What would you call it? Anyone? Let's start with Ishita. What is the pattern?
Ma'am, this is an encapsulated, well circumscribed tumor in a solid pattern of growth.
Very good. And outside you have a follicular pattern. Excellent. But now here you see that this tumor was encapsulated. It broke through its capsule and has produced a second capsule. Okay, encapsulated, solid. But if you look here, it's also papillary, right? You can see a papillary tumor here showing multiple previous breaches and reconstitutions of its capsule. Excellent. This is a small intestinal tumor. So what is this? Identify the patterns. Now let's go to the next person. Kiran, come on. What is this pattern? Left-hand side. Kiran, are you there? Kiran is gone. All right. Ankita. Are you there, Ankita? Also gone. All right. Kinjal. What's happened to everybody? Everybody's gone?
Cords, sensor and cords.
So, Tinu, are you there?
Yes, ma'am.
All right. So what is this pattern?
Indian file pattern.
On the left-hand side, what is this? Tinu, you can't identify this? Jaldi. Cords. What's the middle pattern? What's the middle pattern?
Nests or
Nests. Islands and nests. And what is this pattern? What is this pattern? Cords. Yes, there are some cords, but what is this? Yes. This is epithelial with spaces. This is epithelial without spaces, right? This is epithelial. So what are they? Huh?
acinar pattern.
Acinar tubular pattern.
Yes, could be. So now, infiltrative tumor. Yes, composed of islands, cords, and glands of monotonous cells. Yes, they all look the same, except that their pattern is different in a collagenized and vascularized stroma. So what is this? Because that's vascularized, this is collagenized. So once somebody tells me this, I know what the diagnosis is. What is the diagnosis? There's only one diagnosis in a small intestinal tumor. What is it? It's a neuroendocrine tumor. It's a carcinoid. See, you describe the pattern and you have the diagnosis. Okay? So, leiomyoma, please, no. Carcinoid, neuroendocrine tumor, carcinoid in the small intestine. Okay, what is this pattern? Phyllodes, yes, leaf-like pattern. We saw that. Biphasic pattern, both stromal as well as glandular. Okay, this leaf-like, you see all these little leaves sticking out. Yeah, it's actually the ducts that are going in now. Whether the ducts are branching or the stroma is popping out is very difficult to say because they are so complementary. Phyllodes pattern. Here is another one. Now you would say this looks like a Phyllodes pattern, but this one is solid. Yes, there are some spaces, but those are the ducts. Here, this is fibro. It is a papillary pattern with you have got very broad papillae, but they are going into a space because in ovarian tumors you don't get solid Phyllodes like tumors, right? So there, in a breast I would call it Phyllodes. Here I will call it something else. And what will I call it? Cyst, because there's a cyst. Adenofibroma. So sometimes, depending upon what we are looking at, we use different terms. Here's an ovarian tumor. Now what will you call it? What is the pattern? There was cyst, adenofibroma. Here what will you call it? Papillary cyst adenoma. Because it's papillary, there is a cystic space into which these papillary are going, and it's benign, so it is called an adenoma. Now what is this? This is encapsulated. You see myxoid over here. There is an ossification in the capsule. It's the same tumor that we saw before. This is an encapsulated, collagenizing, and myxoid tumor growing in cords with ossification in the capsule. You say that to me, and I know what the diagnosis is because it's a soft tissue tumor. It's an ossifying fibromyxoid tumor. See, simple if you just get your description right. There you are. Identify this pattern in the ovary. What is it? Just tell me the pattern. Hey, what's wrong with you guys? Ambika, what is this? Is Ambika there?
Large cystic space present.
So it's a follicle. Yes, this is a follicle. This is a DNC. So what is this? What would you call it? This is follicular and cystic. This is what? Glandular. No, this is a glandular pattern. And if you see, the subnuclear evacuation, etc., this is the secretory phase. But this is what we call a glandular pattern because the endometrium has glands and glands secrete. And in this case, you can actually see the secretion in the glands. You cannot call this acinar. You cannot call it ductal. Okay? All right. What is this pattern now? And full marks to anybody who tells me this pattern.
Is bone.
This is bone, yes. This is a matrix, but what is it? It's growing in a pattern. So what is that pattern? Very good, Naina. Naina has answered it. This is a trabeculae. So we call these trabeculae of bone. Okay. So this is a normal trabeculum of bone. What you see in the marrow, because this bone is lamellar. This bone, these are also trabeculae, but this has got osteoblasts around the periphery, and therefore this is woven bone. This is lamellar bone, that is woven bone, but both of them are trabeculae of bone. Okay? So this is the trabecular pattern in which woven bone has been laid down, and this is normal trabecular normal lamellar bone of the marrow. Okay, what is this pattern? Jaldi, 5 minutes and I have to finish. What is this? Huh? People can't see the pattern. This is a tumor. What is its pattern? Does it have a pattern?
No.
Ah, this
Patternless.
is the thing. Monotonous sheets. Every cell looks like every other cell. It is a monotonous sheet. What is this? And you've seen it before.
Ulceration.
Ulcerative. Very
Ulceration.
good. See, with an overhanging edge or an undermined edge, whichever way you want to say it. Okay, ulcer with slough in the floor and an undermined edge. What is this pattern? This happens to be something on the scalp of a woman. You don't need to worry about it, but what is this pattern called? Huh? What is this? Come on, come on. Ah, there, Naina is very good at it. She said that this is a perivascular rosette. Absolutely. This is an angiosarcoma with perivascular rosette. See the vessel in the center, which is the normal vessel, which has an endothelial cell that is picking up the vascular marker ERG. And this is the tumor. See? So it's a perivascular rosette. I'm not talking about true and false. So now last, why do we need to recognize patterns? Why? And I've been saying this. It is to learn the language of pathology, to understand and to be understood. Okay? For us to be able to trigger thoughts in our heads, to make good observations and interpretations. I said to trigger thoughts. What do I mean by trigger thoughts? If I say comedonecrosis in a breast, I know in a breast tumor, I know that that has to have an introductory cast. If I say, you know, which we didn't discuss today, but if I say that this is a pattern in which I have loss of polarity, which is limited to an squamous epithelium, I know that this is dysplasia. Okay, loss of polarity is a pattern. When I look at this is normal, polarity has been maintained. When I say that there is an epidermal vesicle, then I know what I'm talking about. I'm talking about pemphigus. And when I say for this, within a squamous lining, you are seeing a stellate pattern. Then I know that this is an ameloblastoma. So when I say the right word, fascicle, stellate, vesicle, comedo, I say loss of polarity. All these words and phrases trigger thoughts in your head. So you have to learn these phrases, because they, even when you are making a description in your head, you should be able to trigger thoughts. Ultimately, you make a good diagnosis. And from a good diagnosis, you understand pathophysiology and pathogenesis, okay? Which means that you are probably be able to tell the behavior of a lesion, okay? So I will say now, good luck with your language classes, because it is a language class. Both Siddharth's class and my class was about learning a language. Remember this, you don't learn a language by memorizing a dictionary. I will not be able to learn any language by memorizing a dictionary. So you cannot do it by memory and recall. You learn a language from language speakers, like myself, like Siddharth, like your teachers, who use it appropriately and will help you to use it so. Okay? You learn a language by listening, reading, and using it in everyday life. Okay? To become a Pandit, of course, you will have to have a passion. So I don't see why any of you cannot become a Pandit. Okay? Just have the passion. Just say that I must learn this. And you know what I say, and I said it that day at the end of Siddharth's talk. If I want to learn, and I have a friend who wants to learn, I will sit and describe to my friend something that my friend has not seen. Okay? And if my friend is able to recognize whatever it is that I am describing and make a diagnosis, then I am using the language appropriately. And it doesn't have to be difficult cases, simple cases. Okay, you just describe an endometrium to your friend who doesn't know that you have picked up an endometrium and put it on your stage, and see if that friend can actually identify it. And you don't have to say, oh, I see endometrial glands and stroma. No, I'm sorry. That's not the way you describe. I see glandular tissue, then describe what that regularly spaced in a stroma that is made up of, short, oval, small cells. Then you describe whether the cells have got subnuclear vacuoles or whatever. And if that person says, you're describing an endometrium in the secretory phase, you have done your description well. Okay, so that is how you learn. You learn by obviously taking the help of people who know and who use language appropriately. Okay, so, but if somebody is careless about their language, I'm sorry, there is nothing that I can do nobody can do anything to help you. All right. So, ladies and gentlemen, I hope you have, I will put a stop to this thing now. Okay. I hope that you have really had a taste of what patterns in pathology are, that you have, you will now use these words, what Dr. Siddharth taught and what you heard today, in your everyday descriptions, whether you're doing it in your head or you're doing it loudly, with your teachers have asked you to describe something. Okay, are there any questions? Were there any questions in the chat box?
No, ma'am. No, ma'am, but the chat box is, ma'am, do it. Good remarks. Somebody is wishing happy Doctor's Day.
Oh, yes, today is Doctor's Day. I have to wish all
Yes,
of you
ma'am.
happy Doctor's Day. Okay, to everybody.
Thank you, ma'am.
Thank you, ma'am.
Bye.
And wish you the
Take
same,
care.
ma'am. Happy
Bye,
Wish you the
bye.
same,
See
ma'am.
you. I wish you.
Bye-bye.
Yeah, I wish you all the same. Okay.
So on Thursday,